Today, we're going to talk about critical aspects of quality improvement. And most large organizations have a lot of infrastructure, they're inpatient institutions, and they have formal quality programs. But today's discussion is for clinics and outpatient practices striving to improve quality of care and safety in a value-based environment that may need some help getting started or understanding where the importance is and how to convince C-suite executives to invest in quality. So today we're going to discuss how quality meets sustainability in healthcare. I'm Joanne Byron. I'm your speaker today, and I want to thank you for taking your precious time to attend this webinar. I know everyone is very busy, so I'm hoping you get a lot out of this presentation. The American Institute of Healthcare Compliance, we're a licensing certification partner with CMS, and we're very proud of that. We provide online and live training, webinars, free education, videos, free educational articles to healthcare professionals. The information covered and discussed during the webinar today is for educational purposes only and should not be used as consulting or legal advice. Our agenda today, I want to preface with healthcare quality has long been measured through the lens of clinical outcomes, patient safety, and regulatory compliance. Yet a new imperative has emerged, one that integrates environmental stewardship and social responsibility into the very definition of quality. Today's presentation, we're going to cover challenges faced in today's environment, how to prioritize projects, how to identify contributing factors, and where we can locate national patient safety goals specific to ambulatory care. Technology and artificial intelligence, well, we all know that is developing very quickly. So we are going to spend a little time on technology advancements and addressing quality in our workforce concerns. If we don't have a strong workforce that isn't burned out, well, everything relies on our workforce and technology. The last topic is factors that can lead your organization to high quality performance. And if you like today's presentation, I welcome you to join me and Dr. Olivato at our Auditing to Quality Compliance Standards workshop in Nashville in October, where we're going to spend 2 whole days going through extensive training on quality standards and root cause analysis and corrective action plans. So why is the American Institute of Healthcare Compliance presenting this webinar? This presentation is to provide information on what patients and payers want so that you can meet those quality expectations for reimbursement purposes and to improve care provided within your community. Quality of care is increasingly tied to reimbursement to incentivize better patient outcomes and more efficient healthcare delivery. Value-based care models link payments to quality metrics and reward providers who deliver high-quality, cost-effective care. This shift is driven by the need to improve patient experiences, reduce healthcare costs, and address disparities in care. The Joint Commission, CMS, AIHC, and other organizations offer free quality information, which I'm going to address shortly in this presentation. And there are lots of links in the PDFs that you can use to get all this good free information. Now, when you download today's PDF slides, it's going to take you to our blog as well, to our YouTube channel, and also to our certifications page that lists online courses, workshops, certification training camps. Dr. Stacy Adkins is a member of the AIHC Education Department team, and Dr. Adkins recently published an article for our blog entitled Quality Meets Sustainability, a Rising Imperative in Healthcare Compliance. And as Dr. Adkins states in her article, sustainable healthcare is the practice of meeting present health needs without compromising the ability of future generations to meet theirs. It requires balancing 3 interdependent domains: economic, social, and environmental sustainability. Recent policy developments underscore the growing expectation for healthcare organizations to consider sustainability, as we have seen with CMS, Joint Commission, and the World Health Organization. Compliance specialists can anticipate that sustainability metrics may eventually intersect with reimbursement, accreditation, and public reporting, similar to how quality measures evolved from voluntary to mandatory over the past 2 decades. In addition to meeting sustainability expectations, payers have been and will continue to tie reimbursement to performance. Healthcare providers are going to need to continue to be incentivized to prioritize patient well being and focus on preventive care and chronic disease management, which benefits the community, the organization's reputation, and it benefits the payers. But most of all, it benefits the patients. We are also consumers of our healthcare system, and we know how it feels when you go in and you don't feel that you're being heard, that you don't have things explained in a manner that is meaningful to you. So it's important that we take a holistic approach to patient treatment and treat our patients the way we want to be treated, or our children, or our parents, and our other loved ones. And we need to do it with greater emphasis on integrated care, meaning healthcare providers work together to address a person's physical, mental, behavioral, and social needs. And that's kind of difficult with the traditional way that we have been practicing medicine over the past decades under a fee for service environment. But by taking the holistic approach, in this manner, providers treat an individual as a whole person rather than focusing on just a specific health issue or disease. According to the Centers for Medicare and Medicaid Services, or CMS, the term value based care is used to describe healthcare that is designed to focus on quality of care, provider performance, and the patient experience. The word value in value based care refers to what an individual values most. The link on this particular slide takes you to the CMS value based care page. Now, the next slide is an illustration of a small portion of that page. I suggest reviewing this page as it provides additional links to person centered care and the patient's role in value based care. It will give you some insight into what the government deems important. So the first thing you'll see is defining key terms at the top of the page, CMS's page. And it defines things such as accountable care, care coordination, integrated care, person-centered care, and value-based care. There's much more on this particular page to check out for those who are interested. Let's focus on value-based contractors next. So, what do value based contractors look for if you go into a value based contract arrangement? Well, they're focusing on improving healthcare quality while controlling costs and examining several key quality and safety issues. Now, safety and quality are linked together, and a few areas they evaluate are clinical outcomes and effectiveness, patient safety, the patient experience, efficiency and cost reduction, health equity, provider performance, and accountability. Now, I want to ask you a question before we move on to our next topic. Does your organization perform reviews or audits to determine where your strengths and weaknesses are when it comes to meeting quality and safety compliance standards? So, answer yes, you do it routinely. Yes, but only after there's been an incident or a complaint or a report filed. No, you don't believe that your organization is doing that, or you just don't know. You may not be privy to that type of information. So if you can go ahead and Give it your best shot. So this is great. 69% do some form of a review and determine where the weaknesses are, where your strengths are. So you can lead with your strengths, and you need to strengthen your weaknesses when it comes to meeting quality and safety compliance standards. And so you're doing it at least annually. 17% say you do it as a follow-up after an incident or a complaint. And that's good that you're doing that, but it's nice if you can kind of get ahead. And having those incident reports gives you some insight on where your weaknesses are and how to strengthen them. And then you need to go do ongoing monitoring to make sure that the problem doesn't occur again. For the 8% that say no, you don't believe so, it might pay to look to see what your department can do on its own independently to see where your strengths and weaknesses are in relation to quality and if patient safety. Even if it's in medical billing, there are patient safety issues. Cyber safety is patient safeties, securing patient information so you don't damage them by identity theft or people gaining access that shouldn't to their patient records. And if you work in a clinical area, I think it's extremely important to see what you can do, maybe on a very small scale. That's the best way to start. All right, let's talk about challenges to providing safe and quality care. There's a lot of challenges, more than what I could fit on this slide. A lot of it has to do with resources, the money, and having adequate staffing. If you don't have an invested workforce and you don't have the resources you need to launch a really good program, it becomes a daunting task. So let's talk about several factors that can contribute to quality issues in healthcare clinics. This includes inadequate staffing works against you, high turnover, people that are burned out, poor communication between the providers. They're not exchanging information about one particular patient. Lack of robust safety protocols. Patient-related factors like cooperation and understanding of treatment. Are you able to train the providers to use layman's terms and to relate to the patient on the patient's level? And that goes along with healthcare system structure and available resources that you have, all which play significant roles. Although most practices have been working on these issues, we all know that this is a short list of challenges to meet the quality compliance standards needed to successfully succeed financially. So let's take a closer look at several of these items individually. Insufficient staffing levels and inadequate training can lead to increased workloads. So the people that are your star performers, well, they end up getting put through the ringer. They end up getting burned out because the other people who are slackers or, they went to the football game, they call off the next day, and they're just not reliable. They're not invested in the work that they do. Ends up putting a burden on your star staff, and then you end up with turnover. So insufficient staffing levels or insufficient stars that you need to have on your team is extremely important. It's a huge challenge. It causes, if you don't have enough stars, higher error rates and decreased attention to patient needs. The worst thing is to walk into a clinic or into any healthcare setting, any setting, period, and the staff is on their phone, not related to their job. They are not paying attention to who is in front of them. It's rude and it's very difficult to put your foot down to say, don't bring your phones to work or don't use your phones at work. Because in this day and age, the younger generation just they're attached to their phones. So you have to figure out how the best way to address some of these challenges that taking care of one particular problem, which is lack of attention due to technical devices that are personal and not professional, um, can take you a long way to addressing that. Most states permit physicians to personally train assistants. That's another thing. And insufficient staffing levels or inadequate training, the doctors can personally train their assistants. And in many states, physicians are permitted to personally train unlicensed staff to perform certain delegated medical tasks, provided that they meet certain criteria. Some states allow for on the job training for medical assistants, where physicians or other medical professionals can instruct assistants on tasks. The physician must ensure that the unlicensed individuals are competent to perform the delegated task. And you need to make sure that there is appropriate supervision provided. Now, this supervision can be direct, meaning the physician is present in the office suite and immediately available to that person, or general, where the procedure finished under the physician's overall direction and control, but presence is not required. So it depends on the task and the state regulations. Now, if the training is primarily on the job, some legal opinions recommend written verification of competency by a licensed provider or qualified licensed professional, such as a registered nurse. I strongly recommend documenting all training, no matter what level of that person. It could be the provider training an RN to do something that she is licensed to do, but maybe has never done it before and he wants to start delegating it to her. Could be an RN training an LPN or a certified medical assistant on doing some things. And certainly, if you have unlicensed people that have had no formal medical training and you are delegating something to them, that you have very detailed training, documented policies and procedures, and then a return demonstration to show competence. Those are all compliance related things that are very important when it comes to your workforce. And the delegated tasks cannot constitute the unauthorized practice of medicine. So you can't delegate somebody writing orders for the doctor. The doctor has to verbally give the order, write the order, and then other people can execute the order. And also, the delegated tasks cannot be beyond the physician's normal course of practice and expertise. And ultimately, the physician remains responsible for the outcome of the delegated tasks. One thing about RNs and LPNs, they can get malpractice and liability insurance. Unlicensed people can't get that. And so they are taking personal responsibility and risk if they should do something wrong. And your corporate malpractice insurance and your attorneys cannot cover errors that someone else has made. So it becomes a very complicated situation. One of the things that I recommend doing, which is very cost effective, is under the physician's malpractice insurance company, there's a risk department, and you can call the risk department and ask for a risk attorney or a risk expert to come out to your practice. It's free. It's part of the malpractice premiums that you're paying. And they can come out and see what you're doing and how you're doing it and give you advice on how to better document things, or to say you shouldn't be delegating that task to this level of staff workforce member, and help you to manage those types of risks which is going to help you improve with the training of your workforce and give you a little bit more confidence on delegating tasks. As we just reviewed, integrated care requires professionals to communicate. That is difficult, to change the culture to meet the demands required to meet quality standards of care. Lack of communication between providers contributes to other misgivings, such as inadequate communication with family or the caregiver. It can cause a misdiagnosis, delayed treatment, and even medication errors. Have you noticed if your providers are motivated in this new quality care environment? And if they are, then there are the patient socio-demographic variables, level of cooperation, and severity of the illness that's being treated, which can all influence the quality of the care that the patient receives and also exhaust providers and clinical staff. The absence of well-defined safety protocols is another challenge, such as infection control measures or proper medication administration procedures. Those can all lead to hospital-associated infections or AIHAIs. I had a hard time spitting that one out in an outpatient setting, while less extensively reported than the typical hospital-acquired infections or nosocomial infections. And you might say, well, we do a good job with infection control and we meet all of OSHA's guidelines. Uh, it may be harder to trace infections that perhaps were acquired by a patient coming in and visiting in your clinic than it would be in a hospital environment. So these kinds of infections can arise from various healthcare procedures that you're doing in the office or in the outpatient environment and lapses in infection control practices. Reports highlight outbreaks and adverse events linked to breaches in basic infection prevention, such as improper disinfection of equipment and unsafe injection practices. Injections should be done by the provider or a licensed RN or an LPN if they are competent in those areas. But often injections can be delegated to unlicensed staff. And regardless of their licensing or lack of licensing, have you ever done a return demonstration where people show you that they are competent and that they are practicing appropriate protocols for infection control? And there's common breach areas: injection safety, equipment processing, sterilization, and environmental cleaning. Those are always frequent areas of concern. Some examples of breaches is reusing single-use items, improperly disinfecting endoscopes, reusing finger stick blood glucose meters. Oof, those are examples of practices that can lead to infections. Now, you might not think that those things are going on. Do you know for sure that your staff is adhering to what we think as nurses or providers are common sense? The impact outpatient HAIs can lead to serious illness, prolonged treatment, which increase the costs to the patient for out of pocket and to the insurance companies, making them very unhappy, and increased overall healthcare costs. Healthcare professionals in outpatient settings should be trained on current infection prevention guidelines and best practices. This is an area that I really encourage everyone to focus on. Lack of standardization. If you don't have standardization, then it causes variation. And when you have unwarranted variation, which refers to differences in healthcare practices, outcomes, and costs that can't be explained by patient characteristics, preferences, or even evidence-based clinical needs. It exists when care that should be clinically equivalent varies in a way that is just not justifiable. It's distinct from warranted variation, which is justifiable due to the patient individual needs and individual preferences. Several factors can contribute to a lack of person-centered care in a clinic setting. These include organizational and structural issues, such as time constraints, staffing shortages, and lack of resources, as well as individual factors like resistance to change and communication barriers. Additionally, traditional practices, power hierarchies, and even patient characteristics can hinder the implementation of person-centered care. There's many other contributing factors that can impact your facility from meeting quality compliance standards. So, before we talk about how to set priorities, I have a polling question for everyone. When a quality or safety incident occurs, does your organization perform a root cause analysis and corrective action plan? That was one of the answers in the first polling question, but I want to really isolate this particular question. So let's say there was a needle stick incident, or a wrong medication was administered, or the wrong dosage was administered. Can give you an example of a mistake where a doctor gave an order and the workforce member put the order in for the medication in the computerized order entry to send to the pharmacy. Pharmacy filled it, refilled it. It was the wrong dosage. It was the right medication, wrong dosage. The patient kept getting sicker and sicker instead of feeling better and better. Went back to the doctor numerous times. They couldn't figure out what was wrong. The doctor made the error, and the person who entered the order didn't catch the error. The pharmacy didn't catch the error, and it harmed the patient. Could that you need to do root cause analysis, and how can you prevent that from continuing to happen? So we have 68% say yes, you do that. I applaud you. I know it's a lot of work, but it is so important, and you get valuable information if you do the root cause analysis correctly. And then for 25%, you don't formally document it as in an incident report and require the department manager to address the problem. And that is at least addressing it, and that's important as well. So that's good that you're doing that, but you could probably improve on being more consistent and standardizing how you approach these issues. And for 7%, you're just not sure, and that's fine too. I'm glad that you answered the question. Let's talk about prioritizing high-risk areas for patient safety and quality of care. And in a clinic setting, it means we have to learn more about the factors that contribute to patient safety risks and the impact on the quality of care in our practice. What should the first step be when you're identifying a priority high-risk area, crucial for effective intervention and improvement? What is the first step? So if you state it begins with conducting a risk assessment, I agree with you. It's the best place to start. Yes, doing an assessment, complete risk assessment, very important. Just like we do for compliance and overall for like HIPAA compliance, medical billing compliance, documentation compliance, we can also do a risk assessment for patient safety and quality of care. Regularly evaluating processes, systems, and settings to identify error-prone areas. Well, that's crucial for proactive risk management, which is easy to say, but can be difficult to implement and difficult to keep it going. So if you don't have a program in place, start by interviewing key providers and managers and review any documented incident reports from, let's say, the last 1 to 2 years Isolate one or two factors posing the most risk or harm to patients and start there. Start small because it can be overwhelming and then you can't manage it and it won't be ongoing. Now, again, you can always consult with your malpractice insurance company's risk attorney. They send professionals out, they do it for free. It is a really good place to start. It gives you resources that have already been prepaid through the malpractice insurance premium, gives you experts in the field, and they can come in and really, if you say, I don't know where to start, they can point you in the right direction. And it doesn't cost anything except your time. Your organization may also benefit from retaining a qualified consultant if it seems too much to do on your own to conduct that initial risk assessment, which will help to identify the priority areas of focus and for them to perform a root cause analysis and give you a corresponding correction action plan. Because if you can get that first step done and get launched, you can probably take it over and not have to have an ongoing consultant unless you can afford to do that, which would be nice. You can consider training as an option to learn more about compliance with quality standards and how to perform root cause analysis and corrective action plans, such as the workshop that we have coming up and through learning from virtual learning. We have auditing for compliance online course with certification, and there's free internet resources. But stick with well-known or government agencies such as AHRQ or the VHA National Center for Patient Safety. And after deciding how to identify the highest risks, view them and break them down to particular key factors. So let's talk about the breakdown of key priority areas of focus. It involves identifying, assessing, and mitigating potential risks to patients. This includes focusing on factors such as medication errors, which I think happen a lot more often than anybody would like to really admit. They may go undetected, or we may not document it and admit that they've happened. Infection control, diagnostic errors, falls, patient misidentification, particularly if your EHR and risks related to cybersecurity are at risk. If any of these items are identified as doing harm or being an incident in the past, or identified as having a high potential of becoming an incident, then put these at the top of your list to mitigate first. If you're not tracking prescription errors or medication administration mishaps, I encourage your organization to start. Control inventory of samples. And be sure your workforce members are not helping themselves to samples that may be prescription only without the provider's order. This is a form of a medication error, and I can tell you it happens a lot in practices. I've also, as a consultant, I was walking down the hallway and I was there to do a risk assessment in general and looking at the clinical and the administrative functions. And I walked by and I saw a nurse giving herself an injection in the thigh. She was helping herself to migraine injection medication. And she didn't have an order for that. um, I also walked into one practice where the provider's wife is a pharmacist. She was helping to manage the practice, but going down the corridor to the examination rooms, there's a little shelf on either side of the hallway, and it was lined with free samples of not over the counter medications, but prescription medications, where anybody, staff or family members or patients could just help themselves. That's something that you can correct very quickly. You need to make sure that you have accurate medication reconciliation. You need to make sure that you track samples. You have to make sure that your samples don't have expiration dates, because if you're giving samples to a patient to get started on a medication and it's expired, that's a medication error. You want to make sure that if you're doing medications in the office, injections or anything like that, there's proper dosage calculations, and that there's clear communication with patients about the medications. If there's any severe side effects, um, they can always ask the pharmacist, but sometimes the patients may not think to ask the pharmacist. They're relying on you providing a lot of that information up front when a new medication is prescribed. Getting the proper medication is a critical part of any care plan. Medication errors are a significant source of preventable harm to our patients. Improper dosages, drug interactions, and wrong medication administration can lead to serious consequences. Staff training and CPOE, or computerized provider order entry, can really help reduce some errors, such as mistaking the name of a medication because of a sound-alike medication, or entering the wrong dosage when sending the prescription to the pharmacy. Medication mistakes occur due to lack of standardizing the process and only including appropriately trained staff, as well as failure on the part of the healthcare professional to read carefully or not asking the right questions about drug interactions. And fatigued staff also contributes to patient care errors, not only medication errors. Improve communication between specialists. Um, we need to ensure timely access to diagnostic information, and we need to involve patients in the diagnostic process. Younger people want to be involved. Older people might get confused. They may have hearing loss or maybe some cognitive deficits. So make sure you try to have caregivers or younger family members help to make sure the patients understand as much as possible. Delayed or incorrect diagnoses can have profound and lasting impacts on patients, leading to delayed or inappropriate treatment and potentially worse outcomes. Factors contributing to diagnostic errors include cognitive biases, which is when a clinician's biases can influence their interpretation of information and can lead to a misdiagnosis. Communication breakdowns, which can be attributed to insufficient communication between patients, physicians, and other healthcare team members, resulting in vital information being missed or misunderstood. And lack of clinical decision support, such as limited access to up-to-date information, evidence-based practices, or tools like clinical decision support systems, all which can hinder accurate diagnosis. Effective communication is the bedrock of patient safety and quality care. Actively involve patients in their care. Encourage them to ask questions and report any concerns. Yes, this takes more time, but this is part of value-based care and quality care. Breakdowns in communication can occur at various points in the care process, leading to errors and dissatisfaction. High-risk communication areas include patient-provider communication, patient-related factors such as language barriers, cognitive or physical impairments, and failure to adhere to treatment plans can increase the risk of medical errors. Clear and empathetic communication between patients and providers, it's essential for shared decision-making, patient engagement, and adherence to treatment plans. Failure to instruct a patient for self-care is a big one. When a patient leaves medical care or leaves your office, they need to know how to take care of their injuries and illnesses. An essential part of medical care is instruction for self-care after leaving treatment. Not giving patients the information they need to help themselves is a form of a medical error. And I'm talking about going on beyond going onto the internet, printing something off, making a bunch of copies, and handing it to the patient. They may not be able to understand that. They probably looked it up themselves and they're coming to you because they need a better explanation. This is where delegating patient education to well-trained staff, your nurses, and so forth can really help be an effective time saver for the provider. The provider can go on to the next patient, the nurse can come in and maybe do that patient instruction for self-care and answer questions, and anything they can't answer, they can get back to the patient after talking to the provider. Inter-team communication, where there is ineffective communication among different healthcare professionals, can lead to coordination of care issues and errors as well. So we all know that we can do better in these areas. Implement strict infection control protocols because we need to address healthcare associated infections. Make sure that everybody is washing their hands. When I go to the doctor's office, I feel better when the doctor comes in, goes to the sink and washes their hands right in front of me because they just touched the door handle. And the door handle may have been touched by me, other people, and then he puts his hands on me. We want to see cleanliness of the environment, the exam room, the waiting room, appropriate use of antibiotics, because healthcare associated infections pose a significant threat to patient safety and can lead to increased morbidity, mortality, and healthcare costs. Improper medical device use, mismanagement of medical devices, which includes lack of adequate cleaning, not just of the exam room surfaces between patients, but sanitizing equipment between each use. Patients that are a fall risk. Assess patients for fall risk. They're not always people that are elderly or people with a rollator or in a wheelchair. We may not be able to visually see that a person is a fall risk. So we want to look at implementing fall prevention strategies and monitor patients closely. Falling is a serious problem for many people with illnesses or injuries. They can have vestibular problems that were caused by an ear infection. They can have dizziness and vertigo caused by medications. Falls are a common patient safety challenge, especially for high-risk patients and those with cognitive or mobility problems. So factors that contribute to patient falls that we need to mitigate is looking at unsafe environments. Are there obstacles, slippery floors, poorly lit areas that could increase fall risk? Lack of supervision. Do we have inadequate staffing or monitoring of high-risk patients? Do your patients know how to escort someone who may be a fall risk, identified as a fall risk? Do they know how to appropriately assist that person from the waiting room to the exam room and to the door when they're done? Medication side effects. There's a lot of medications that cause dizziness, drowsiness, and instability, increasing the likelihood of falls. Improving outpatient safety, it requires both structural reform of office practice functions as well as engagement of patients in their own safety. Coordinating care between different providers remains a significant challenge, especially if they do not work in the same office or share the same EHR. So let's talk about where to locate national patient safety goals, focusing on ambulatory care. The Joint Commission provides national patient safety goals on their website. And we're going to take a peek and also have a hyperlink so you can go there yourself in just a moment. But it involves two related concepts. First, educating patients about the illnesses and medications, using methods that require patients to demonstrate the understanding, such as using a teach-back method. And second, empowering patients and caregivers to act as a safety double check by providing access to advice and test results and encouraging patients to ask questions about their care. Success has been achieved in this area for patients taking high-risk medications, even in patients with low health literacy as a baseline. So this is the link. This is what you will see if you use that link. At least that's what it looks like today. And although Joint Commission largely focuses on hospital care, they now publish these goals for ambulatory care, and it's free. Go in and download them. AHRQ, I've thrown that acronym around a little bit today already. It's the Agency for Healthcare Research and Quality. It's part of the Department of Health and Human Services. It's one of the resources mentioned earlier and provides a page to guide providers according to the type of facility and also measure to track and report. So this is the slide, and each one of those are hyperlinks, and then I bolded the one measures of physician quality. So thanks to significant advances in the field, report sponsors have access to several well-tested tools and measurement sets to use as the basis for collecting data and preparing comparative information. So these are options that you may want to consider for gathering quality data on health plans, hospitals, medical groups, clinicians, and so forth. Now let's take a look at measures of physician quality standards. Consumers are very interested in information about the quality of physician care. And to meet that demand, researchers, medical societies, and healthcare experts have made a concerted effort to address that many issues encumbering physician quality measurement. The next few slides reflects information from the AHRQ physician quality page. Both technical and political issues have contributed to the limited use of physician measures in public reports. Technical challenges encompass the difficulty of constructing valid measures with data generated from small patient populations that you find in ambulatory care, data sources that are not comprehensive, and information systems that are not standardized. Political issues, well, that encompasses the wariness of physician stakeholders and a lack of consensus about which measures are appropriate for reporting to consumers. Then we have the challenge of measuring groups versus individual providers. Physician quality measures can be used to evaluate the performance of an individual physician or groups of physicians that practice together, such as a pediatric group practice. However, while consumers have indicated a preference for quality information at the level of individual physicians, most information on quality is at the level of medical groups or practices. The advantage of constructing scores at the group level is the availability of a larger patient population. When measuring quality at the medical group level, you can create a sample by combining patient data from each physician in the group. It's more difficult to produce adequate sample sizes for individual physicians who do not necessarily have a sufficient number of patients with the disease or condition addressed by a particular measure. The minimum number of required observations needed to calculate a score for an individual performance measure varies. Recommended ranges are from 30 to 50 patients per physician. However, a larger sample is often necessary depending on the characteristics of the measure or data source. Factors leading to high-quality performance in the outpatient setting influences the ability of a practice to delivering high-quality care. You need to be able to invest in the advancement of technology and focus on workforce through training and education. So let's break this down. Artificial intelligence. Physician practices are increasingly leveraging AI for tasks like diagnostic support, personalized treatment plans, and so forth. Automating administrative tasks streamlines workflows and reduces burdens on patient staff. But we have to be wary. It's new, and there could be bugs in the system. So there are drawbacks, which Dr. Olivato is going to be talking about in October. She's going to be addressing a lot on artificial intelligence. There's telehealth and virtual care, which enhances patient access and convenience, especially to underserved populations. The CMS 2025 physician fee schedule expands telehealth access and integration, and in September, there's going to be some deadlines met, and we're hoping that there's going to be a continuation into 2026 for telehealth coverage. Digital transformation, widespread adoption of digital tools like patient portals, secure messaging, and wearable devices all help with real-time remote monitoring and data tracking. And we need to focus on developing and promoting a quality workforce and take a team-based approach. We need to look at expanding non-physician roles, utilizing advanced practice providers, nurse practitioners, PAs, and we need efficient workflow of staff optimization, streamlining, standardizing procedures, automating routine tasks, and optimizing staff allocation helps to contribute to increased efficiency and better patient care. And collaboration with multidisciplinary teams means recreating a culture of safety and changing our mindset to improve effective communication and collaboration amongst all the healthcare professionals involved in a particular patient's case. Being overworked and understaffed leads to burnout and poor performance. So we need to invest time and technology and training to achieve a patient-centered care environment. Empathy, compassion, communication, accessibility and convenience, patient engagement, and education. When you streamline processes and make the patient experience more positive, it often reduces stress on your workforce. Not as many grumpy patients or providers. Financial management and sustainability means getting on board with the shift from fee-for-service to value-based care models. Focus on preventive care. Value-based care emphasizes preventive care, early intervention, and how we can improve population health and reduce overall costs. Revenue cycle optimization. We have to have efficient billing and insurance processes, accurate coding, which is based on accurate documentation, and cost-cutting measures. We need to explore strategies like adopting automation, optimizing workforce allocation, and other cost-saving measures. Change is not only coming, it's here now. Using a quote from Mae West, I never said it would be easy, I only said it would be worth it. Too young to have heard about Mae West. Well, that shows my age. She had it right way back when. What we're saying is that anything worth having is worth fighting for, fighting to create a more sustainable, valuable healthcare system in the United States. It emphasizes that worthwhile goals, relationships, or achievements don't come easily and require a willingness to persevere through challenges. And so let's look at Q&A. We have some comments. How do you feel the documentation aspect impacts the quality of care? How can we help the clinicians know it can improve quality and even aid in conversations with other specialties? Documentation is so important, and EHRs have a lot of automated responses and lack of customization. It over-standardizes how people document in the patient's records. Clinical documentation improvement in the outpatient setting, we actually have a course for that. Having one of your coders or nurses take training in this area. There's training by our organization, but other organizations as well. Find what suits you best, and then have somebody help the doctors with that. A lot of times doctors can take documentation advice better from another clinical healthcare professional, like a nurse or another doctor that maybe you can have head up clinical documentation improvement. We also have a comment about the American Academy of Ambulatory Care Nursing released the second edition of Ambulatory Care Nurse Sensitive Indicator Industry Report, Meaningful Measurement of Nursing and Ambulatory Patient Care Environment. I'll go ahead and get the link to that and try to send it to everybody with my little email thank you tomorrow after the program. Thank you for sharing that with us. We really do need to wrap it up because I know your time is so valuable. If there are any questions I did not answer, Shara is going to be capturing the chat. I'll go through, we'll isolate any questions, and I will get back to everybody who actually registered with the question and a response. Thank you so much for attending today. Quality of care is so important. It's a daunting task. It's a challenge. Start small, Build on that. Use your risk attorney from your malpractice. Use free resources. Consider coming to hear Dr. Olivato and I talk for 2 days in October in Nashville. Um, Everybody have a wonderful day and take care.